So you're going to do the intro?
So we're on now, and we're just for everyone who's watching, just give us a minute. We're waiting for our next panelist to join us. Thank you all for joining. We'll be with you in a minute. We're just waiting for Kristen to join.
Maybe let's see what she says now.
Oh, let me see if I can invite her over here. Let me try again.
Perhaps if you scroll down below the registration area, you can find a place to click.
All right, I just sent her another invite. All right, she should be on in a minute, and just
Jeffrey just sent a new invite to you as well in the email.
She's here. She's saying she's here.
Okay.
Oh, there she is.
Where? I don't see her.
Below, I think that's below us. It says, let's see. Now my phone is telling me to breathe and relax.
All right, I don't see where I can sign her in.
From here, hello. Okay, no, I don't either. Okay, well.
All right, we're going to have to get going. So thank you all for joining us. This is
she's in, Kristen says. You see it?
I don't see her though.
No, just it says from Kristen to all panelists. I need a link to be an interview. I'm in a link. I'm in a participant. Okay.
You got to go into participants, Jeffrey, and then just click on Kristen, and then you can upgrade her. I can't do it from my side.
Okay.
Mm-hmm. Well, maybe I can.
Or else make him a co-host and he'll do it.
Yeah, I'm sorry. I don't see. I got to go in under participants.
Yep.
I don't see the list of participants though.
Go to the right. Attendees.
Participants.
Okay. All right. I see. Kristen Osborne. Kristen. And again, everyone, I am sorry for these technical difficulties. Okay, here we go.
Okay, good.
All right.
Yay.
Here we are.
All right. Thank you, Jeffrey.
Oh, I'm sorry. So we're
actually, Allan saved us.
All right, so let's get going. So
once again,
okay, we're on now. So welcome everyone. This is Eminent Psychotherapists Revealed, a production of Strategic Psychotherapeutics LLC, and I am Jeffrey Magnavita, and I am pleased to be here with my co-host Michael Albert and Kristen Osborne, who are themselves eminent psychotherapists, and very pleased to have as our guest this evening Dr. Allan Abbass, who is a professor of psychiatry and psychology and founding director of the Center for Emotions and Health at Dalhousie University in Halifax, Nova Scotia. Allan, I'm not going to spend a lot of time talking about Allan's credentials because it would take the whole hour, so I'm going to skip over a lot. You can read about him, but we've all known Allan for a long time, and I just want to say that Allan is a preeminent psychotherapist and researcher. I've had the opportunity to watch his videotapes, and if I were to go back into therapy, I think I'd fly up and see Allan. A lot of my friends have seen Allan, and it's been an amazing experience. So without further ado, let's get into Allan's head and have him share his experiences and expertise with us. So welcome all, and I hope this is enjoyable for everyone.
Thanks a lot. Glad to be with you all again.
We are happy to have you here, and we have so many questions to ask you. I don't think we're going to cover in an hour, but we can always have you back for another one.
Yeah.
So Kristen, you had some interesting questions. Think you wanted to.
Well, I'd love to talk about Allan as a clinician, because that for me is really where his work stands out. Having the opportunity to be able to watch a video tape of his psychotherapy sessions and paying attention to how he is as a therapist and what interventions he's using. And one thing that I've always been struck by Allan's work is just how intuitive he is. There seems to be like this paraverbal kind of movement that's happening between him and his patients. And then on top of that, he has these like really timely interventions that he does. And what I would love to know, Allan, is like, what is it about being a clinician that you really enjoy? Because it's obvious that you enjoy your work when you're working with your patients. And can you tell us about yourself as a clinician?
Well, I'll tell you, I mean, my original exposure to psychotherapy, my first exposure to psychotherapy was, if you can believe it, in Montreal at McGill University as a family medicine resident. I had no training before. And so here I am sitting down watching Dr. Davenlou, who founded intensive short-term dynamic psychotherapy, do live interviews. And it just blew me away. I mean, I couldn't, first of all, I'd never seen psychotherapy done before, to see it, first of all. But to see this very active intervention, a very determined clinician, and patients who were bringing themselves in there to do work, but inadvertently bringing up their worst defenses into the in the context of the meeting, and then relenting those defenses, overcoming them, and seeing the actual person stuck underneath. This was really what moved me to do psychiatric training so that I could teach and research psychotherapy, and specifically this approach. To see people come in that kind of rough shape and all walled off and beat up and beat down over years, and see the responses they could have starting in the first session in a lot of cases, and including my first clinical experiences up there, first times of me doing psychotherapy. And I was just struck by what's possible when two people put their minds together to bring a healing experience. And so that's really what's kept me interested in what I'm doing all these years, is really being part of a change, deep change in people. And it's such a privilege. It's also just like, it's gratifying, professionally enjoyable to help be part of that, to be a witness to those changes, and also to help people make those changes, those tough changes, the things they're most afraid of looking inward, afraid of being open with someone else, all the things that we're there helping them to do to heal up the past.
It sounds like you're really drawn to the experience of people being honest about themselves, like with you, in terms of like what they're truly feeling inside versus like what they're showing on the outside.
Yeah, I mean, I've gotten used to when people come in, I think that people come in and they're bringing, because they're worried in one way on a deep level that their emotions are going to break through, that they're worried they're going to do harm, they're worried that something bad's going to happen, and so they bring their guards, as much guarding as they can bring, right? Which is the opportunity, it's the golden opportunity for them to understand and overcome those guards. So happy to see those guards come, because that means that they're going to be able to overcome them, see? So this is something else that's, when I was a physician, as a family doctor, I used to work emergency quite a bit. And actually I did a whole year working as an emergency physician, partly because I found regular medicine a bit boring, actually, and a bit dry, another prescription, do the blood pressure. So, the opportunity, working in the emergency, you have to be alert, you have to be engaged, you have to be ready to do things, you have to know procedures, you have to be able to educate patients. So it was something that, for me, kept my attention. And you also get to see changes in the emergency department. You put someone's shoulder back in place when it's dislocated, they're really appreciative, So this kind of treatment model of course, all changes, all patients don't change that quickly. And, it's not 100% effective approach like anything else, but you can see sometimes quite rapid changes. And it's just great work. I don't know what else I'd be doing. I often think, what would happen if I was still a family doctor at this point, 30 years down the road. I don't know what, I probably would have retired 10 years ago, or gone on to something else.
Right. So
Well,
it's something about seeing people change that really draws you into the work, is what I'm hearing. Like, that's gratifying for you and exciting, and to be a part of that.
Very much so.
Yeah.
Yeah. And also to help people develop, because, about half the people we see on our service, which is a psychosomatic service, people come with health, physical problems, and a lot with neurological symptoms. They're losing their vision, losing their hearing, fainting attacks, pseudo seizures, and other kind of things. You're helping them develop capacities they didn't have before. So this is the other thing, is you're part of helping a person develop, capacities to self-reflect and notice their mind and body responses and interact with others and tolerate emotions and tolerate anxiety. These things that they hadn't had before. So it's new developments, it's skill acquisition. And so you're there helping them build these capacities. That's another quite enjoyable thing to be part of.
Could you tell us a little bit about that process? Because I'm always impressed when I see your work at how gentle you are and how thoughtful, and how you kind of almost minimalist. You kind of say something and it's all done as if you kind of know exactly what to do. So I'm sure that you have your own experience of it, but it's not the slam bam kind of thing that often occurs with therapists doing ISTDP. You're unique.
Well, I think that early in my career, if I pull out some videos from 1993, you'll see a different set of patterns. You see, so first the training was different back in those days, and the expectations was different. But I think over time it changed. I mean, the concept of pressure, and so pressure is encouraging healthy actions. So I think there's multiple ways, obviously, to do that. That on its own activates healing processes in the patient, across multiple models. So pressure doesn't necessarily come from a ton of words. It comes from our intention, our concern, our attention, our attention, as well as our intention. And, eye contact, being present. These things activate a lot of healing forces in the patient. It also activates anxiety and defenses, you see, because they're with someone who's concerned about them and is not going to be put off by the defenses. So, there's nonverbal ways as well as verbal ways to help the person understand and see themselves and to engage a person. So sometimes it doesn't have to be a lot of words. Sometimes it is more words though. And sometimes it does need to be fairly strong interventions. But what I've always done is erred on the side of explaining more and clarifying more before I bring in any heavy interventions like challenging a defense or challenging patterns of behavior in the room. So I lean on making sure that when I challenge, the person knows I'm challenging with them. And then not challenging them, I'm challenging beside them. So that gives me confidence to really, when the time comes, is to go strong with challenge. So I think a lot of times, and I can say for myself as well, in the early years was, if I wasn't sure if the person understood what I was doing or why I was doing what I was doing. So I was hesitant and holding back intervention. So I think that some of these things just change over time. They get more smooth. It becomes more comfortable for us too.
That it's very interesting to me, because I remember when I was first doing this sort of thing. Again, this is the 80s, and I actually had the idea that I couldn't, if I explained what was I was about, then their anger wouldn't be authentic. So I withheld the information. Now, that was not a good move, but so I think what your decision to explain it and spend more time educating, I think, was really the right road.
And Michael, I totally agree with your description of Allan's work. I couldn't have put it any better. But I agree, because I've seen your work, Allan, and it's just exactly as Michael described it. And so I want to take that a little further, because I'm always intrigued and struck by the person of the therapist as opposed to the approach. And I have watched most of the master psychotherapists, either at conferences or on videotapes, and the more I've witnessed the work of people like you and Michael and Kristen and other people, the more I see that it's less about the technical interventions, and to me it seems more like the person of the therapist and the ability to use what you have in your personhood, and which we all see in you, is this sort of patient, gentle guy who helps people feel comfortable with very uncomfortable emotions. I'm wondering where you are in that kind of technical, common factors sort of dilemma.
So as far as the,
I guess the question is,
I could say something about this, Jeffrey.
Can you train? Let me ask this one question though.
Okay.
Can we actually train therapists, or are we born? And I'll show you.
Well, I think that people, there's no question to me that therapists can gain skills. They can become more confident. They can become more calm. They can have better anxiety tolerance. I see these things happen development over video training people over time. And some people, it's a slower road, and different skills come at different time frames. So there's, but some individuals, some therapists, they have so many of the attributes already to start with. They're just very fortunate. Their attachment history is pretty solid, not much trauma in their background, good anxiety tolerance right away. And already intuitively, they're kind of a probing type and a curious type and an engaging person and someone that you like to talk to, So if someone has some of those basics, kind of basic people skills in a sense, that helps. Because ultimately what we're doing here is it's a relational process. It's an attachment. And, so we as clinicians have to be comfortable with some degree of therapeutic attachment. And when we can do that, it brings forward all the attachment trauma that a person's gone through, and it shows up in body responses and behavioral responses and emotions. So we want to be comfortable with that. And I think that if you take that basic and apply it with any therapeutic modality, the potential is that the person's attachment history and all these emotional things that we aim for in our treatment will happen. They'll start to get mobilized. So I remember doing CBT training in the University of Toronto with Martin Anthony and Richard Swinson and others there, and Zindel Siegel was there as well. And so with cognitive behavioral therapy, you're doing, for example, exposure therapy. I was doing exposure therapy, and patients were having breakthroughs of things happening. They were bringing childhood things into the top, bringing these things up in behavioral therapy. So I was the same concerned person I was doing our treatment ISTDP as I was doing cognitive behavioral therapy, and the same responses were happening. And it was so neat because my supervisor was saying, "That's great CBT." And the thing is, I think that when any therapy is going well, there's a lot of things in common. There's an emotional engaged process. There's a relational process. There's a lot of attention. There's focusing in the moment on the here and now. There's an emphasis on emotions that are going around at the time. There's noticing body responses. It's all those things that, we aim for this. We specifically target these things. But I think it happens in other modalities called 100 different things, right?
Yeah.
Well, and I think, Allan, like, I can never separate you from basketball and like your love for basketball, playing basketball, watching basketball. And so when I listen to you talk about psychotherapy, it's always there because, as you were describing, the importance of like intention and concern and attention and eye contact as a therapist. I mean, for me, as I was listening, that's exactly what you need as a good coach too, right? You have to like really be able to pay attention to who's on the court and, what their skill set is and what they need in order to like move forward and to work as a part of a team. And I'm just wondering, like, how much do you think your love of basketball has come into your play as a psychotherapist?
Yeah, I mean, I still play. So, I'm going to play till I can't. And, as a team sport, and I thoroughly enjoy the team component, this is a team of two when you're doing one-on-one therapy. So I think about that, and I think about what I need to bring, what the other person needs to bring, and what we need to agree that we're bringing, like huddling up. And I talk about that, when I'm supervising people. I say, I think you need to huddle up here. You need to, like, are you together in the same place where you're going, for example? So, so you need harmony, you need synchrony, you need to have a shared game plan, if you like. They need to be able to rely on you. You need to be able to rely on them. You can't drag someone up and down the court. You can't carry someone. So you need to have, build a solid teammate, and then you're going about the process together. And just that process of forming the team, and again, it's a common factor, right? It's something that if people have had attachment trauma too much, they haven't had a good team experience. They haven't had that collaboration experience. So, these are corrective experiences that we're bringing in psychotherapy as a general, when it's going well. We're not doing a technique. We're bringing all these things that we're talking about here. But when you do all those things, it does bring up all the feelings related to childhood attachment trauma, and it gives an opportunity to heal those things. So now, one thing you can say is, well, what other things do you do then if you're doing what everyone does, or what's different in these treatment models that, under the umbrella of experiential dynamic therapies or ISTDP, is really being able to understand and work with people who are super walled off and can barely collaborate. That's one group. And the other is people who get so exhausted or so overwhelmed that they can't do the relational piece. They can't sit in the room with us. So this is two main areas that the treatment approaches that we use can help, where other modalities aren't necessarily tooled for. It's a super walled off, detached, defended person with a chronic self-destructive tendencies, and people who are flooded all the time and get a lot of somatic symptoms and get paralysis in the body and a great deal of confusion.
You're really like, it sounds like, creating a bridge between you and your patient for them to be able to attach with you in your work together, and then hopefully be able to do that outside the session too.
Yes. So it's, if they, I said to a patient, we've gone through all this terrible trauma background, terrible feelings he's gone through, horrible things he's been through. He endured the toughest sets of emotions, and all while being open with me and working through it. And he asked me about returning to work. And he said, how do you know when you're ready to return to work? So I said to him, do you think there's anything you're going to run into in the workplace that's tougher than what we did here?
Yeah.
And we both busted out laughing, because the obvious answer is no. Nothing could be harder than what he did in my office. You see, life's easy when they face their own self. See, and being able to master that and go through it and tolerate it. So
I've been listening to Bessel van der Kolk's "The Body Keeps the Score" as I'm walking to work in the morning, and what I'm as you're talking, Allan, I'm resonating with how much of what you're talking about is what I'm hearing Bessel talk about in this wonderful book. He's going to actually be on with us at some point, but the book is just so rich with clinical experience and research. He reminds me a little bit of you in terms of being able to integrate convergent lines of research and different like attachment theory and blend it all in such an interesting and useful way. Do you think that the trauma, what do you think about trauma-informed care? Do you think ISTDP is trauma-informed, or where would you say it is in terms of trauma? Because when I trained with Davin Liu years ago, Davin Liu never mentioned the word trauma in my entire training. And I think if it was ever brought up, it was kind of dismissed as being like non-relevant. And I find it very interesting thinking back to that period.
Yeah, I mean, we've been talking about, teach about attachment trauma as a sort of a setting whereby later trauma make a major problem and recovery is difficult. So the earlier the trauma, the more the person is in childhood tended to have poor anxiety tolerance and a lot of tendency to shut down or self-destructive tendencies, that when they get into an accident or a combat situation, they have huge problems. And it's the layering of later life trauma on top of an earlier base trauma. So Bessel and I spoke because I presented at the conference together at the IADTA.
Interesting.
Yeah. Well, he was very interested in the case I reviewed, and this is a person who gave public consent, for teaching, was trauma from infancy. Okay, it's a person who had both parents either had psychotic disorders or severe dissociative type of problems. And this baby was basically left alone and traumatized on and on and on. And so he was watching this and he was struck by this thing. So he was by how you could work with someone and help to get to the point of this early trauma as a sort of by going through the adult state of the mind into this early trauma where the patient almost had no words. It's like a baby.
Trauma is always the most challenging for psychotherapy.
So you worked from the adult trauma and back into deeper and deeper layers.
Yeah, by using the therapeutic relationship as a bridge, see? By bringing through the feelings that come up with you when they're attached to you, when they have a good feeling with you. And then the next thing is the patient feels like he's this, small, and, and this specific memory is there and all these emotions are pouring through, but there's not many words there, you see? And he was struck that there's only a couple of words because this is like a baby speaking. You see, it's like it's not laid down with words. It's laid down as a body response, a set of body responses.
Would you call that? I call that state memory. Would you call that state memory? Like it's the memory, the emotional memory that's not actually differentiated emotions, but just the state of what the person's stuck in at that time.
I'm not sure on the language here, but it might sound like it's the same thing. There's specific, these are unique memories and the person is super small, like standing in the crib, okay, holding the rails of the crib and calling out and no one being there, no one responding, these type of specific memories, see? Yeah. So, as far as post-traumatic stress disorder, we just published long-term follow-up outcome data showing a lot of hospital and doctor cost reduction as well. So the treatments are very effective with post-traumatic stress disorder.
Allan, like when I listen to you, there's so much like caring in your voice about your patients and other people's patients as well. Like where does that come from? Like, how do you explain like who you are as a clinician, a researcher?
Yeah, that's a deep question. I always had an interest in these things. I think from early life, and I've had adverse events myself in childhood, things that I had to deal with and go through and heal through. But I was on this quest, in my mid-20s, and I started reading all this stuff and looking for all these things and trying to understand myself and try to understand how people work and how I was working. And that was became like a journey. And by fluke. It is total luck that someone said, well, when you go back to do family medicine, what about McGill? Go to Montreal, and they have a short-term therapy model there. Maybe you could get to learn that, because I was talking to people about it. And sure enough, I had no idea what it was. And I landed in Davilou's program. It was just a pure luck. I could have landed in any model, right? So, and again, I never would have seen psychotherapy if I had landed in some other models where they don't show psychotherapy, where it's not right there in front of you live or video. So it was that captured my, held my attention.
And when you're working with patients who have, like, let's say PTSD, they have, early childhood trauma, they're working through their present trauma, and they're saying, like, this is so painful. Like, will it ever end? Can I do this? What do you say to someone like that?
So that doesn't come up much that way.
Mm-hmm. Okay.
Yeah, because really, the way when someone comes in, I'm working with them right away on what's driving their anxiety and what's driving, and I'm trying to quickly, as fast as possible, bringing adaptive forces to bear right now, as soon as possible. So I'm bringing their attention to the here and now in the room with me. In other words, I don't leave much room for hopelessness to kick in. Like, I'm doing things that instill hope right away, so they don't get that kind of hope, like losing hope type of response. And you already are starting the treatment within the minutes of them walking in the door, and they're seeing some things happen, and they can see a pathway, and that's hopefully the way it goes. So when the feelings come, it's very painful. There's no question, and some of these feelings are anxiety provoking or scaring to them. So, but when they get to the other side and they got through something and felt something, it's just such a huge relief for them, right? They didn't hurt you, you didn't hurt them. What a relief. The fear in a person that they're going to kill you or that you're going to kill them. It's just a horrible thing. Living life like everyone's dangerous and that the person himself is dangerous. It's a rough thing to go through.
So Kristen, I like your questions, but this is Eminent Psychotherapist Revealed.
Oh no.
I wanted to, so Allan, sometimes when I'm working with patients, I sit in a state of utter inadequacy and self-doubt. Like, how am I ever going to help this person? And like, I just have no idea what to do sometimes. And sometimes I'm in that state and it's like, oh my God, why am I doing this for a job? Do you ever feel that like kind of sense of like, I don't know what to do? You always seem like you always know what to do when I watch the tape.
No. And I mean, I'm giving a course June 2nd to 4th. It's going to be one whole day. It's going to be on cases I struggle with, and these are current. So, or I had a lot of significant challenges with. But put it this way: there are patients that the way they tend to engage us is to encourage us to feel that way, right? I'm not unique. None of us are unique.
Yes, you're unique.
No, we're all going to feel that way because that is what we're expected to get into. And then we find a way out of it.
So are you saying we're absorbing their the projection of something from them in a way that we're trying to metabolize for them?
In some cases, yes, 100%. So I would feel that in the same way as someone else. Like they want you to give up too.
Well, that's a relief. Woo!
Some patients want, in one way they're desperate for you not to give up, but at the same time, part of them wants you to give up and quit on them.
Yeah.
Right.
Yeah.
So we absorb. I guess you're saying metabolize it. That's a good way to put it. Like you'll experience it. What about hating the patient, feeling rage towards the patient? Yeah. There's some patients again that do things. They hate themselves to an extent in some points in time that they draw you to feel that way too.
Yeah, I wrote a chapter in I think it was Goldfried's book on hate and countertransference. It's a very interesting and sort of almost taboo subject. It was great that a book was out on that.
Yeah, and by you experiencing it, you get to know what they're relating to themselves is about, and then you can help them deal with that. You see?
Yeah, that's a good point.
Again, we're not unique. None of us are.
So you're using everything you experience.
Yeah.
Even the inadequacy, the self-doubt, and what we experience just being with people in such incredible pain and trauma states.
Yeah. And then another thing I'll just add that relates to it is sensing the body responses of the patient on the mirror processes. Like, so, you know, we're all wired together. If one of us feels something, we all will feel something. And so a person feels joy and love, you'll feel that, you know, a person feels sad, you feel sad, you know, and the same with body experience of anger and rage, you'll feel a bit of it. You'll get all warm and energized and aggressive feeling. You'll feel it. It helps them feel it.
And what do you think about, oh, go ahead.
Do you verbalize your experience or with people who you think can handle it? Yeah. Occasionally
I will. But usually they can tell. I mean, they know, they see a tear in my eye, they see me smile in response. I might say, like, what about here? You know, so, so for example, there's a rage coming up. So they're telling you a situation where their neighbor abused their daughter, okay? And I'm saying, so what do you feel when you tell me about that? How do you feel inside your body? And like, so if I feel anger coming up in my chest and it's all heated here, and if you know, I'll say to the person, what about up here? What do you have there? Okay, what's the temperature in there? All right, if they're not used to feeling anything, they don't notice that there's so much heat boiling out of the chest, right?
Yeah.
It's just not in their conscious. So I'll say, what about in here? Okay, so what I'm cueing them to, and the patients know this anyway, that you feel what they feel. They know that. They know that you're experiencing something with them.
Now, when you talk about, like, we're all connected, our minds are connected, I agree with that. The question that I'm, like, curious about is do you think that it's almost a struggle between the patient wanting to pull us into their resonance so they have company in their misery, distress, and hopelessness, and we're trying to pull them into hopefully a more coherent resonance? Do you think it's almost like a struggle for a resonant phenomenon? Who's gonna be like the main attractor state?
Who can persuade who to do what? If you think about it, look, I mean, we all know stories of clinicians who get drawn into very destructive relationships with their patients. And so there's a pull. Now, so for us, we want to be determined and clear what we're there for, right? So that we can have our base on what health is like, what relating in a healthy way is like, what healthy emotional processing is like, what self-care is like. So we have our base there, right, as a sort of relatively solid stance that we have. And see, that puts friction in the patient who is struggling with a self-destructive drive, and they're trying to attach and they're trying to heal, and at the same time they're terrified and they want to sabotage it. And this sort of complicated process happens, but we're a solid base, right?
So there's no question, and because as you were talking about this, I've been increasingly aware of this ache in my chest. And I can only assume that it's something about the way you're talking that is bringing this sense of closeness. So I can see why you're saying that the people you're working with clinically are picking up these nonverbal signals from you. I think the softness, your eyes, which are very expressive, and the kind of encouragement and belief in what you're doing, which then makes them feel very, very good about being close with you and connected to you. Would you say that's in line with what you're saying?
Yeah, I think that's one of the common factors. You know, if I was doing cognitive therapy, I'd have the same enthusiasm. You know, if I believed in it, and I mean, look, we all know that in the models we use, there's a cognitive component anyway, right? Obviously, we're challenging beliefs. You know, we're doing other things that theoretically belong in other models. Yeah, absolutely. It's about, you know, I called the book that I wrote "Reaching Through Resistance." It's really about one person reaching through to another person stuck underneath, who was beat down over time and has been, you know, usually a fairly young person who's been beat down and, you know, shut away and afraid to be attached and afraid to be cared about and afraid to care about anyone else, you know. So yeah, I want to put a hell of a lot of pressure on that person to come out from behind that resistance as much as they can do. And I want them to do it as fast as they can, because look, life is time limited in a sense, right? This is not forever. You know what? I want to see someone when they're like 70. And they could have had 5 sessions. I worked with a fellow 67, okay? And he had 30 years of medication and talking to this the person and talking to them. And then he had like, we just worked together for like 5 sessions. It was like a life-changing thing for him at 67. So why 67? Why not 27, right?
Yeah, but
why not 17, right?
Don't you think
Anyway,
the problem with our field now that almost so many patients come in that have been treated with medication and no one has ever engaged them in this way, and they're called treatment refractory. They've had every treatment. Sometimes when the clinicians get frustrated, they get ECTs. Yeah. And how can we change this, do you think? How can we, like what you're saying just makes me feel like Michael, like I got this great feeling that there are other people out there that are doing this. What can we do?
Well, I mean, it's a challenge working in the systems, in the healthcare systems, because they have their own bunch of issues and a bunch of layers of organization that makes it hard for them to change and move. And it makes them hard for them to bring in anything that's a little bit off out of the norm. So for example, CBT is the dominant model inside systems, or plus DBT. So when you bring this model in, even though a variety of studies have showed it's better, it brings a better outcome even in our system, there's various issues and resistances built into the systems that don't allow a focus on early trauma, that don't allow a focus on emotional processes, that sometimes don't even allow video recording. So there's the systems itself is a challenge to move systems. And that's different in different countries, by the way, because some countries where we have training programs like Norway, for example, it's become built into government hospital and public mental health systems, where they pay for training, they support the people in training, they make videoing and everything possible, and they examine the evidence for themselves. I mean, so, you know, you need the administration structure needs to want to innovate, needs to be comfortable with something that is a little bit different looking, that has video, that's sort of open, and that does recognize that, yes, people are hurt in childhood. You know, there is such a thing as childhood trauma. I mean, it's a tough pill to swallow if an administrator themselves has had huge childhood trauma that they've never talked about. And then we have a model that's all about dealing with childhood trauma. I mean, that's a tough pill for them.
Yeah, that's a good point.
What is it? Courtois says that the most traumatized segment of society are the children.
You know, Allan, I'm watching like Jeffrey and Michael respond to your enthusiasm, and when you watch this video, you'll see you really were lighting up, you know, as you were talking about your work.
I mean, I got the three of you guys like an old reunion from
yes, it's pretty good, huh?
But like, what do you do to like, you know, take care of yourself so that you can be so present with us and present with your patients? Like how do you take care of yourself as a psychotherapist, researcher, academic?
Basketball.
Well, that's one. It's definitely, you know, I mean, you know, I'm literally, I sit here on Zoom, see my patients, and I've got my basketball shorts on. At noon, I go out and I'm shooting hoops in the yard. Okay, this is my lunch. So it's not much. I just go out there with a shirt on and away. But definitely sports, team sports. But as far as like other things like case review, peer support. So we do video case review as a team every week. We review our cases with each other. Teaching is also, I find it it has a therapeutic element, because when you prepare for it, you really got to scrutinize your work. You really got to think about what you're doing. You got to really put yourself into that. And so that is, I find that really a strengthening thing as well, teaching.
Allan, you are an excellent teacher. I mean, I've sat in on some of your seminars, and you know, to be able to put, and you're demonstrating that now, to be able to put this complex phenomena into terms that like you can understand is such a gift. And I'm so happy that you continue to go around the world and do what you do, because it's a real gift to have someone like you who is committed to training and teaching.
Well, thanks a lot.
Yeah, someone who's humble about it too.
Yes.
And Allan, when you're teaching your students about, you know, how to be present with their patients, like what advice do you have for them?
So it depends on who the students are. So I have psychiatry residents, we have psychology interns, we have practicing clinicians, and we have clinicians of different backgrounds too. So sometimes family doctors or psychiatrists. And so there's some differences there in terms of the professional base a person has and what their natural tendencies are. I try to kind of, again, push on the edge of where the person is on certain skill sets. So if they're not very good at attending, I really stop the video a lot and we point out a lot of things. So I get them to attend into the process of what's happening. I try to help them zero on their emotion and body response as well. I try to help people learn how to review their own video so they can self-supervise in some way. And I reveal a lot of how I'm thinking about the case and what I'm noticing. So I'm trying to be as transparent as possible about what my process is. I provide written materials as well, and and case materials, and so it's different things to help them along the way. It's a variable as to the challenges are different for you know, each one of us developing as clinicians. So yeah.
Do you find that the pandemic, where people have been kind of locked in and forced to use video, has actually made it more acceptable and easier to get people to look at themselves?
Look, I think it has to have. There's gonna be a ripple effect going forward where every clinician, even the ones that didn't want to see themselves on their screen, because I can tell you a lot of them don't want to see their own face. Right. It's just, you know, it's a sad thing to think that someone doesn't want to see their own face, but it happens. And so for that reason, videoing is a real challenge for some of our colleagues. They weren't trained in it. They didn't see anyone's videos. It's like, you know, it's a scary thing. So I hope that helps with that. The other thing I think is huge, at least up here, is access to psychotherapy for people that aren't in city hubs. This is great. You know, we get to see people from a distance that we never would be able to see this often. So it's been there's a good effect on healthcare delivery and in different jurisdictions through the use of technologies like this.
So I have a couple of questions that are coming in from our viewers. So one is, Allan, how do you handle disclosure? That's general, but can you just try to address that one?
So disclosure in terms of
I think self-disclosure, like obviously you seem like to me you're very transparent, but I guess the question is how much.
Okay, so with patients, when you start the process and get rolling, I can tell you it's very unusual for the person to really want to know that much about you. What sometimes will happen is the person will ask you something about you just to see if you're in there and how you're going to react to it. Okay. And then you just say it, and then it's done, and they move on. They just want it's like almost like a test.
Yes.
But you know, where we live here is not a very big city, so people know one another anyway. So it changes the dynamic a bit because, you know, people, you know, they see me here, they see me there, and I mean, I'm also kind of visible because I'm over 6'9", so I can't hide out kind of thing. So there's like a familiarity that happens sometimes already. But I don't do a lot of like upfront disclosure that I decide I'm going to disclose. No, I don't do that.
All right, that's helpful. And another question, can you talk about how you learn to work with anger in your patients?
Yeah, so the video training is all about helping people identify and feel within their body and express complex feelings that are buried inside. So buried inside means that there's grief that's never been felt. There's guilty anger, anger that's inhibited by love, that is pushed inside and stuck under anxiety. So when I'm working with people, it's really around these complex of emotions, okay, love included, with rage, and all mashed together in a sort of a guilty ball of anxiety, usually in the body. So it's not anger or rage, it's body sensations related to mixed feelings, including love, including sadness, including anger or rage energy, including guilt about anger. So that complex of those four feelings is what we're really interested in, helping the person recognize, tolerate, and work through together with us.
And how do you learn to be comfortable with your own anger? Do you think you need to go through your own psychotherapy as a psychotherapist?
So by anger again, we're referring to the sensations and emotions in our bodies of anger. See, we're interested in the body sensation of the emotion. So the body pathway of anger, comes from the feet up to the ears, coming up each spinal level with heat and energy that removes all anxiety on the way up. And there's an urge to do something with the hands, with the body. On its own, I just consider free heat in the winter. Because it just warms up your body. And then I know what I'm dealing with. I know that this is what the patient is in contact with. So on its own, see, it's not something that's, a problem or anything. Now, in the early training years, especially, my own emotions from childhood, my own attachment trauma were coming up. My own feelings were coming up in concert with the patient. So the patient would have feelings coming up with me. I would have feelings coming up with the patient about our attachment. And the patient feels them and I feel them, okay? It's like a double breakthrough thing happens, okay? Now, you don't spend time talking about your part, you deal with it after the session, but use that as a sort of a therapeutic tool to deal with your own childhood trauma. Is just stay present, attach, work hard with the patient, study your videos, and get used to feeling things. And that makes it a lot easier for the patient, because then they don't see us getting too uncomfortable and, or feeling bad in our bodies, because they get worried about us if we feel sick in our stomach or we don't feel good. It worries the patient. It shuts them down to some degree too. So,
well, do you ever try to use these physical sensations as the educators, that you talked about using resistance or defenses that way? These things are kind of the gold road toward the answers. So if they can convert these things, that you find that works as a kind of metaphor.
Very much so. I mean, when they can access the set of emotions that come up with our effort, our annoying effort to help them, okay, because it is, they appreciate it and it's irritating. When they can feel those sets of emotions, it's the doorway to all the other mixed feelings. You see, it's like just a gateway opens. So to do that, we got to be present and help them do their best and help them not hurt their own effort. That's kind of it in a nutshell. But think about it. That's what psychotherapy tends to want to do, right? Mm-hmm. What we're doing, certainly as emotionally focused therapists, we're doing that. That's our daily focus. But it's a standard of psychotherapy, really.
So we have about 4 minutes before we're going to sign off, but we usually do a wrap up afterwards among us, and anybody doesn't have to sign off at 8 o'clock and can join us for our interview wrap up. Last time was maybe as interesting as the interview, or maybe more for some people, but please, if you can stick around for this afterwards, join us. Thank you all for attending tonight. For those who are going to be signing off at 8, and again, if you want to hang around and watch our debrief, Allan, can you join us for a few minutes of debriefing?
Yeah.
Okay.
Yeah.
All right. We're going to sign off now for people who need to get off at 8, and then we're going to open up to our more informal.
Stop recording, Jeffrey.
Okay.
Do we stop recording or do we keep going?
I think we'll keep going with the recording.
Okay. All right, cool.
We're going to be
Well,
transparent.
If anyone's going, hope you have a good afternoon, evening, or morning, whatever it is, wherever you are.
Yeah, thanks for coming.
Yes,
And
it was
thank you,
delightful.
Alan. This was great.
I'm going to step away for just a minute. I'll be right back.
Okay. All right.
And Jeffrey, I didn't know that we're going to keep the debriefing, so I'll be here for a few minutes, but then I have to go. So
Okay. That's
yeah.
okay. We can hopefully, Alan, you come back another time. Alan, I thought this was just wonderful. Thank you so much for taking the time to do this with us. Sharing your expertise and experience with us is a delight, really.
Well, thanks. Glad we could do it.
Yeah, yeah. So what's like what's going on with you're very busy like traveling and training these days, or what?
Yeah, that's because of COVID. All the immersion courses I usually do in person in Norway, Sweden, Denmark, usually something in Italy, and usually often something in the UK and Switzerland. Those are all online. So there's like a ton of online courses this year on personality disorders and somatic symptoms, and next week, a couple of weeks from now, on resistance. And I just finished 2 on fragility with dissociative disorders, 2 courses. So one on functional neurological disorders coming up in July. And so there's a lot of those I'm preparing for and delivering from here, from my house.
How does that work? I know that's probably nice to not have to travel so much, but how does that work in terms of what do you think the quality of the training is when you in person with your 6'9" frame is not in the room?
Well, you're missing the social part in between. We try to do sometimes a few events during the breaks. It's not the same, obviously, but I can tell you that the feedback has been quite positive. People think that in some ways it's better because they're in their own home. They don't have distractions. They can, if they're feeling emotions or whatever, that's fine. It's sort of private for them a bit more. Plus, the way I've been doing it is I'm doing a constant play-by-play in the chat. And so they're seeing my whole stream of consciousness while we play the videos. And I got them all, the videos are all English subtitled now. So it's for people that it's not their first language. Some people they're finding that is better than in person, where we stop and chat. So the continual text thing seems to really, really work for some people. So I think it's going to end up being something that's here to stay. The next year, I have like 2 of these courses already set. I got one on depression in December, and then next year there's going to be one on fragility and somatic symptoms. I think the 2 main ones are. But
so where can people go to find out where you're presenting, Alan? If people are watching.
Alan, I'm going to interrupt. I just have to say goodbye. So it's great seeing you.
Great.
Okay.
All right. Thanks a lot.
I'll catch you later.
It's AllanAbbass.com is the sort of one way to get to the website, or reachingthroughresistance.com. It's and it's got a page with the links and all that for the courses.
Excellent. Good.
And it's publications, by the way. You can access at least 100 of my publications on the publications page.
Great, wonderful resource. So do you think that this new technology and people are getting more comfortable with it, do you think this will increase access to high quality training around the world?
I think so. I mean, because, in the course I did, 2 courses I did last year, one, there was 350 people from like over 20 countries, okay, including India, okay, where there's a training program. And some other countries, there's no way they're going to come to Halifax for a course. Who would cost a fortune, and they travel for a day, 2 days to get there. You know what I mean?
Mm-hmm.
It's a great innovation for people that first of all financially can't afford the travel, and because of the economies in the areas and just the time it takes. So I think it's great for distributing knowledge.
Yeah.
Do you
we'll make sure we get the link on Psych Incubator for those who come to watch the recorded version of this later, so they can, if they want to jump into some of your training, that'll be available to them.
Okay.
You use videos of actual sessions, which
I do.
Do you ever use role plays with other therapists where you essentially
to
demonstrate?
a limited extent, I do in supervision, where we're doing supervision groups online too. So I do to some extent on those supervisions. I haven't done those with the big groups because there's such a range of knowledge levels in the bigger groups that I'm trying just to get a sort of a core set of information and then expand it over the 3 days, for example. And so I'm trying to keep it within a certain parameter so that it's not too far, you know what I mean? But in supervision, yeah, we do that sometimes. Some people do a lot of that. I'm not super adept at it, at role playing. Do you use a lot of it, Michael?
Yeah, we essentially, can play the role of somebody in this kind of with a certain problem. One of us does that, and one of the other people is the therapist, and we kind of rotate it around. But what's interesting is that it becomes very popular to be the patient, to be the one role playing the patient, and that I think
Therapy.
we get therapy from it. Interestingly, as we do it from our friends.
Oh, okay. Interesting. Yeah.
So I think with one of these things that you bring to this is this kind of unifying of all the different things that are happening. You actually are very careful not to kind of reject or separate out or make fun of anything, and kind of talk about how we all draw on very common things. In this group, it's phenomenal. I mean, I find myself hearing you and saying, well, sounds right to me.
Yeah, I mean, very inclusive. I like that.
Yeah.
So maybe we should wrap up now.
Okay.
Allan, we'd love to have you come back again.
Yes.
And again, I want to thank you very much for taking the time to do this. This was a lot of fun for me.
It was great.
And I'm sure our participants enjoyed it. So we'll be in touch and keep up the good work.
Yes.
Thanks for having me.
All right. Good night, everybody.
Pleasure. Bye-bye.
Thanks for attending. Bye now.
All right.